So I'm going to be hopefully giving you a bit of an overview of a nurse's perspective for PARP inhibitors. So I do have a couple of conflict of interests. So I am a part of the National Advisory Board for Lynparza, and I am a clinical trials nurse at Princess Margaret, so I do deal with several different types of PARP inhibitors. So the objectives of the talk today are going to be to hopefully understand how PARP inhibitors work. Over the last couple of days, I'm sure we have a better understanding, if you didn't have an understanding coming into it, with all the different interesting talks with PARP inhibitors. Understand the difference between germline BRCA and somatic BRCA, and why this is important for patients, and to describe the common side effects associated with PARP inhibitors, and hopefully give you some tips how to manage some of these patients on PARP inhibitors. So I like pictures, so you'll see this picture essentially quite a bit through my presentation, and apparently I like bubbles as well. You'll see that as we go along. Okay, so as we've mentioned already this morning, ovarian cancer is the 8th most common gynecology cancer. It is the 5th leading cause of cancer-related deaths in women, and about 70% of women with ovarian cancer are diagnosed late, usually around stage 3 or stage 4. And there's no screening test for ovarian cancer. So each year, approximately 2,800 Canadian women are diagnosed with ovarian cancer. And as we heard earlier this morning, that often 1,700 approximately will die of the disease. So ovarian cancer just is a busy slide, but I just wanted to pinpoint on there that ovarian cancer, although we talk about it broadly, it's not actually one disease. There's several different subtypes, and if you can see, I don't know if you can see very well, but there are different mutations associated with the different disease types, and hopefully, future, there are now some targeted therapies that will look at those, but hopefully in the future we'll have them for all of those. So this is just, again, a picture, just an overview of sort of where the current treatments are with ovarian cancer. We have surgery, chemotherapy, which most of you, I'm sure, are quite familiar with. We do have anti-angiogenesis, so Avastin and Cediranib, which is still under clinical trial, although Avastin has just recently been approved with Health Canada for ovarian cancer patients with platinum-sensitive first recurrence and who have never received a VEGF before. And it's also for platinum resistance who have not had more than 2 lines or have never had a VEGF treatment before as well. Then we have the PARP inhibitors. I'll go into more detail, obviously, about that. And the new hot topic, of course, is immunotherapy. Radiation is there as well, and hormones sometimes can come into play. It just depends on the stage and where things are.
Every day, tens of thousands of DNA lesions occur in cells, requiring constant monitoring and repair. Repair of single-strand breaks requires the enzyme poly-ADP ribose polymerase 1, or PARP1. A more severe and genotoxic form of DNA damage is the double-strand break. In normal cells, DNA double-strand breaks are repaired by homologous recombination, which requires the proteins BRCA1 and BRCA2. Use of the sister chromatid as a template ensures this process is generally error-free. Deleterious BRCA mutations can be hereditary and predispose to ovarian and breast cancers. In deleterious BRCA mutation carriers, non-cancer cells are heterozygous and can still repair double-strand breaks faithfully by homologous recombination because they retain one functional BRCA allele. Loss of function of the second BRCA allele disrupts homologous recombination repair, forcing cells to use other error-prone mechanisms, which can result in genome instability and cancer formation.
Okay, so PARP inhibitors and how they work. Every day, cells are damaged, and they have DNA damage. They rely on the enzyme PARP, which is poly-ADP ribose polymerize, which is why we use the acronym PARP. We don't say that saying that too quickly, it'll drive you crazy. So essentially we use the acronym PARP. It is an enzyme. They also rely on the BRCA1 and 2 protein to repair DNA. So essentially when you think about ovarian cancer, there's two main repair pathways. And you have the PARP and the BRCA, and if you have a single-stranded break, if you think of the PARP as a repair person, I don't want to say repair man, I want to be politically correct, but if you think of a repair person, it goes in and it helps repair and helps regulate that repair pathway. Okay, that's one single-stranded. When you have a patient who has a BRCA mutation and they've got already a bit of a hindrance, per se, they're missing that BRCA protein, and then they rely on the PARP to come in, again, that repair workman, to repair it. Because they have the two, they rely a little bit more on the PARP. If you add in a PARP inhibitor, think of it as your work repair person falling asleep, and then that repair can't happen, right? So essentially, those cells can't regenerate and hopefully will shrink and die. And that's sort of how I think of how a PARP inhibitor works. And that's kind of how I explain it with patients as well.
So what you're saying is that it's not allowing the cancer cell to
Regenerate. That's right.
Versus the healthy cell to have a repair.
That's right. Yeah. Yeah. It's a little confusing, and I can talk to you after about how because even trying to break it down, so when I go in every day and talk to patients about this, it's a little different than trying to stand up here and explain it. I use pictures, I'm talking about all that type of stuff, so it's a little hard. So actually, I spoke with Dr. Oza before coming here because I've been researching for this presentation, trying to figure out what is the best way to explain it. So we have an actual animation that we're going to come up with, so that might be a little bit easier. So instead of me trying to do my little workman and that type of stuff, but you can try and use that as well with patients. So it might be a little bit easier. Because when you get into repair pathways and DNA and all that type of stuff, a lot of patients are glazing over. So yeah. So BRCA1, BRCA2 test results. So as Heidi very well this morning did a talk about that. So you have your germline BRCA1 and 2 positive. You have your BRCA1 and 2 negative, variant of unknown significance. So again, we were having that bit of that conversation during the question and answer period about patients, that have this unknown variant. We don't really know what it means. We don't know the implications of it. So those patients may actually go back and be followed by genetic counselors and have more testing done in the future, as we were talking about. So it's something that we need to keep an eye on as nurses for those types of patients. And then we have more recently the somatic BRCA1 and 2 positive, and I'll chat about that a little bit. So BRCA1 and 2 germline, that's when patients carry this mutation in their blood. This is hereditary, and relatives may possibly carry that gene as well, okay? This requires discussion with counselors, nurses, and understanding the implication that this may have on the patient as well as their family. When you look at the BRCA1/2 somatic, it's a little bit different. It's actually in the tissue. It is not hereditary that we know of at the moment, because it is very new, it is under research. But the thing about patients that have this somatic BRCA, they may actually respond to PARP inhibitors very similar to the way that patients with the germline BRCA respond. So again, it's a bit of a new concept, and it's still in the research setting, and I know that GOC is hopefully pushing towards having it all on pathology as well, so that will help patients in the future. So there is a bit of a difference, just to outline it, and I'm sure most people in the room probably know that women with mutated BRCA1 gene have a 25 to 65% chance of developing ovarian cancer in their lifetime, and women with mutated BRCA2 gene have a 15 to 20% chance of developing ovarian cancer. So there is an actual difference between the genes. So these are the different PARP inhibitors that are in development currently: niraparib, rucaparib, olaparib, Lynparza. So for the last 8 years, have been calling this drug olaparib, and we've recently changed it to Lynparza. So I will probably flip back and forth, but it is the one same drug. It was also known as ADT, anyway, sorry. And BMN 673, ABT 888. So I'm going to focus my talk on the first three because those are the ones that I have the most experience with. I don't want to talk about things that I don't know about. And even more so, I'm going to even focus a little bit more on olaparib, again, because I've been treating patients for about 8 years on olaparib. Now, how many people are familiar with the grading system? A few? Okay. So clinical trials, we use CTCAE, which is the common terminology for criteria for adverse events. So essentially, if you go to conferences and talks, and they will talk about grade 1, nausea, grade 2, fatigue, those types of things, this is where this comes from. It's a grading system to help avoid bias. So essentially, when a patient comes in and says that they're nauseated, well, one patient may mean nauseated worse than another patient. So it's trying to find, to avoid the bias in reporting, to making sure that everything is across the board as standardized as we possibly can, okay? It is common language as well. Common for healthcare professionals, yeah. So I'm just gonna kind of give you, and I know it's a busy slide, I don't know if you can really see, lost my pointer. But I just wanted to point out a couple, the next two slides are just a couple of ones that will be related to PARP inhibitors that we've used, these ones, and I'll talk about them. And, okay, so just to kind of orientate, LLN is lower limit of normal, okay? So if you look at a neutrophil count, okay? So if you think it's 0.6, so essentially that's grade 3, okay? If you have a white blood cell count of 3.2, you've got a grade 1, okay? And if you have anemia of 85, it's going to fall into the grade 2 category, okay? Pretty straightforward when it comes to the numbers one, because it's right there. You can look at it. You flip open your book, and the numbers are there, so it's pretty easy. Gets a little bit more challenging when you get into these ones, because you have to rely on the patient to tell you exactly what they are. Are you able to see? That's okay. Exactly what they mean. So if a patient comes in and says, well, I've been fatigued, I'm really tired, I'm not really doing all my stuff. And so you, as a trials nurse, our responsibility is to kind of try and fit it into that category. So grade 1, grade 2, grade 3. So it's asking questions, is this, are you up and about throughout your day? Are you doing your regular work? And the patient goes, well, I'm fatigued, but, I'm jogging 3 miles a day, or, that type of thing. And I'm thinking, well, I'm definitely fatigued. And, so it's really trying to know the patient and what it is that they're reporting. It's also trusting the patient in what they're reporting. Because sometimes we'll have a patient coming in and saying, I'm constipated. I say, okay, well, what are you taking? How many times are you going? All those types of things. And then you drill down, well, we're actually not taking any laxatives, not doing anything. So you're trying to grade that, trying to help them as well. So this is essentially how we look at AEs or adverse events. So just a brief background of where we are. So now I'm going to go into the clinical trials. So we do have one clinical trial with Tesaro, which is niraparib. It was a maintenance study versus placebo. So the dosage was 300 milligrams once a day, okay? So this was what was reported at ASCO from one of the abstracts. Essentially, this was the adverse events breakdown. So essentially, we're seeing nausea, anemia, fatigue. They were seeing some changes in blood counts. Now, I do want to remind everyone that this is all disease sites, so it's not specific to ovarian cancer, just to keep that in mind. There was no febrile neutropenia noted. So this was our experience at Princess Margaret. So we had nausea, fatigue, insomnia, thrombocytopenia, and anemia. And the bubbles don't represent numbers, so we didn't have more thrombocytopenia than nausea or anything like that. It's just font, truthfully. So if you look back at the previous slide, there wasn't a whole lot of difference in what they were reporting and what we actually saw in real life. Yeah.
So was this post-starting treatment? What was the level of these issues? Because some of these patients were already dealing with recurrent disease, right?
Yes, so this is platinum-sensitive patients. I think it was second line, and they were in the maintenance setting. So after they finished their carbotaxol, they went on to have niraparib versus placebo. So the other thing that you need to keep in mind is it was a randomized trial. So, niraparib or placebo. These were the things that we were seeing. Okay. So I just want to show you kind of an idea of what it is that we saw, and then, the management that we are helping our patients with. So we did see some early onset of anemia or thrombocytopenia, and then in other patients it was more gradual. So it's really hard to know and to be able to say to you directly, if you're treated with niraparib, you will have this by this day, or, that type of thing. The management that we had, transfusions as needed, assessing other possible causes. And I think this is one thing that, if I can, take home message for nursing, going back and using these agents, is you have to assess what else is going on in the patient and what they're also may or may not be telling you. So you're looking at comorbidities, you're also looking at medications or herbal supplements that they may be taking that may be interacting with medications. So that's something that, as a nurse, it's good to know and good to be asking patients. So if you see somebody coming in with anemia or thrombocytopenia that's way down in their boots and we don't really have an explanation why, they may be actually taking something else that may be interacting with the drugs. So what we also did, according to protocol, we were allowed to do drug holidays, and when I say drug holidays, it's essentially holding the drug, okay? And dose reductions as per protocol. This is still in clinical trial, so you will see as per protocol kind of in all of my slides. Insomnia. So it wasn't really on the ASCO reports, but it's something that we did see in our patients. Baseline insomnia, if they had that to begin with, then it seemed to increase that side effect. We did treating early, so we were having patients call us, this is what's happening, we try and give them sleep aids. Also, the basic things, decreasing stimuli before going to bed, and again, looking at other causes. Were they taking other things, just before going to bed that caused them not to be able to rest as comfortably? And again, drug holiday or dose reductions. Yeah.
When it comes to this particular issue, I attended a presentation a couple of days ago about insomnia in the general population, and there was a lot of buzz about melatonin. So would that be allowed on this trial?
So this specific trial, I believe it is. It's not one of the hugely prohibited drugs. I can't say for sure without going back and actually looking at it. But there is a lot of patients coming in saying, can I use melatonin? Yeah. So nausea, again, if they have a baseline nausea or if they were prone to nausea during their chemotherapy, that seemed to be heightened while they were on clinical trial. Again, it's treating early, assessing for other things that may be going on. And what we did find is patients seemed to tolerate it as time went on. So if they did have it, if you got past the first few cycles, then they seemed to be able to tolerate it a bit better. Again, dose holidays or dose reductions. So fatigue. Some patients did feel some fatigue intermittently, and some felt it actually at the very beginning, and others, again, there's no real science. I can't put, definitely by day 15 you're going to be feeling better or anything like that. But generally speaking, patients got used to the new norm, and things that we suggested were listening to your body. So if you need to rest, then you need to rest. Like it's okay to do that. Report your symptoms, and again, looking at other things that may be attributing or increasing the risk of fatigue to them. Some people, it was the anemia that was causing it, to feeling them so fatigued. So doing blood transfusions, and then a dose reduction if needed. The other thing that you have to keep in mind is that these patients would have been 6 to probably 8 weeks post-chemotherapy. So if you think of your regular population who's just come through carbotaxol, and then they go on and they do their thing, they're still fatigued for quite some time after. So then adding in another agent for maintenance therapy, it's something that we need to think of. Okay. Yeah.
Sorry, I keep on.
That's okay.
So how many of these patients, because I know we send patients from Kingston to Trondheim, and I sometimes wonder how much of it is the drug and how much of it is the travel.
For sure. I don't have a good answer for it, but I know that specifically in clinical trials, they wait long periods of time. They're here more often, that type of thing, as well as coming from far distances. So there is definitely a part of that, and I think that comes down to knowing the patient, knowing what's happening. When I say comorbidities, it's not just because they've got diabetes or anything like that. They come from 5 hours away. They got up at 3 o'clock in the morning to get here for their appointment. Yeah, they're fatigued. So it's knowing that part of it as well. So moving on to drug number 2, it's rucaparib. So these were the 3 trials that we participated in. The first one is known by this, but it's called Ariel 2. The second one is Ariel 3, and then the following one is the phase 1/2. It's the Clovis 10, essentially, is what we called it, okay? And the NCT, so if you were to go on clinicaltrials.gov, you could find more information about those there. In 2015, Clovis got the FDA breakthrough therapy of destination. Distinction, sorry. What that means is essentially a drug that is to treat serious or life-threatening disease. The preliminary evidence is showing good response, so therefore the FDA is going to be looking at possibly approving the drug. And Lynparza had that a while ago, and now we're in a different phase of that with the Lynparza drug. So it is inclusive for germline and somatic BRCA1 and 2 patients. So again, this is the reported AEs associated with rucaparib, and you notice not really that different from the niraparib. You were seeing nausea, vomiting, constipation, liver function test, fatigue. The other one I want to point out for rucaparib is dysgeusia, which is taste changes. So that was something that we did notice. When you go to my bubbles, you will see that we did see that when we were looking at our patients, as well as acid reflux. So in order to help our patients on the rucaparib with the nausea and the vomiting, taste changes, and that type of thing, baseline nausea, you're going to hear me say that quite a bit. It does increase it, and if you're educating your patients, which is what we're hopefully doing today, and as you go back and do that with your patients, you may see that they have an increased bit of nausea. It does seem to lessen as time goes on, and they do get used to it. Taste changes started very, very early, especially when they were in the early sets with the drug. Essentially day 2, they were noticing taste changes. So we do suggest that you treat prophylactically with Stemetil or metoclopramide. Treat it early. For those patients that say, oh, no, I never had any nausea, I'm not going to have any nausea, they refuse to take it, and then they're calling Val, I've got nausea. It's like, okay, so let's treat this as early as possible, if not prophylactically. Patients do tolerate it as time goes by. Try different foods or different fluids. So I had one patient who was used to drinking bottled water, and so she actually just changed the type of water that she was drinking, and that helped her. Other things like with our basic nursing, changing from metal to glass or those types of things, that might help as well. Assessing for other causes, herbal supplements, vitamins, hydrate as needed, okay? And again, this is still in clinical trials, so drug holiday or dose reductions as needed.
Herbal supplements are defined patients are actually.
Varies. It really does, yeah. We generally say try to not take, especially in clinical trial in my setting, because I just don't know how it's going to interact with the drugs, right? But it does vary. Some people, we had somebody come in and, I just have this little package. I just want to take the little package, and we have no idea what's in the little package. So it very much varies, as well as, high doses vitamin C, all of those types of things. Mistletoe, yeah. Constipation, so I do want to spend a little bit of time on constipation. However, it's probably an ovarian cancer talk that could take up a whole other talk. So ovarian cancer patients are prone to constipation. Obviously, we all know that. We need to manage it early. The thing about oral medications I find with patients is they actually forget that they may be prone to constipation because they're so used to people saying, it's the antiemetics, you need to make sure that your bowels are working during chemotherapy. Then they go on an oral medication and they forget that they should be on an actual bowel regime. So as nurses, I think it's really important that we keep reminding our patients that they should be doing a bowel regime and making sure that they're looking after that part of things. hydration is needed, report symptoms, and then assess again, are they changing their diet? Have they done anything else? And drug holidays or dose reductions if needed. Okay, so again, patients, may feel it right away, and other patients were having an accumulative effect. Again, as I said with niraparib, patients do seem to get used to the new norm. So, if a patient was cleaning their house, doing the laundry, doing the dishes, seeing all the patient, or seeing all of their, looking after their grandkids, doing all that type of stuff, and they come in, they say they're, fatigued, and I'm like, well, yeah, maybe you shouldn't be doing all of that stuff all at the same day. So it's trying to find that balance of what is the new norm. Listen to their body, rest if you need to rest, it's okay. Report their symptoms, and again, as we've talked about, also if anemia is causing the fatigue, then look at a blood transfusion as needed.
What was sort of did you have a threshold for transfusion?
So it's in the protocol. So for these drugs, it would be in the protocol. So it would let us know whether we needed to look at dose reductions or whether a transfusion. So usually patients that are symptomatic, and then whatever the institutional standard is for if it's below 80 or some places it's below 90, then we would look at doing a transfusion. But again, it comes down to the actual patient and what me at 80 versus somebody else who normally runs around 90 would be different. So the one other thing that was a little bit different with rucaparib that we saw was elevated liver function test. Patients were generally asymptomatic. It was very early onset. It does tend to resolve or plateau. And there was no real lasting effects, and that's all been reported in the ASCO abstracts and everything. So this one is really important when you're looking at other medications or herbal supplements, because I do remember a few patients coming in, oh, no, I'm not taking anything, and their ALT is, 400, and you have no real idea of what's happening, what's going on here. So then, digging a little bit deeper, oh yeah, I am taking, this, but it's not really that big of a deal. So that's a really important thing when you're seeing things that you don't really have an answer for, is looking at those herbal supplements or vitamins. So anemia, again, is very similar to the rucaparib. Some patients had it early, some patients had it gradual. Some patients were symptomatic and others weren't, so they would come in with a hemoglobin of 95, 80, 75, that type of thing, and they just didn't feel any different, so it just kind of depended. Transfuse as needed, as for the protocol and how the patient was feeling. Again, dose reductions or dose holidays. So just so that everybody is aware, I don't know if you're going back and looking at patients on rucaparib or niraparib. These are still in clinical trials, so you do need to look back at your protocol. Don't go back to your, treating places and say, well, Val said this, and I need to do that. You do need to refer to your protocol, or your monitors are going to be upset. So put that there. So a little bit more experience, as you can see here, with all of the lists of trials that we've worked on with olaparib or Lynparza. So it dates back quite some time. As I said, I have patients that I've been treating for just over 8 years on, so we do have more experience than that with olaparib with patients on it and on clinical trials. The bottom one, there's not a lot of information on, but I'll go into that. It's the SAP or MAP program. So what that is a special access program. Okay, so now I just want to talk about the Lynparza or olaparib regulatory indications. So probably most of you know that EMA, which is in Europe, the Europe Medical Advisory Board, so it has approved olaparib or Lynparza for monotherapy for maintenance treatment in patients with platinum-sensitive BRCA-positive disease. And then FDA recently, again, most people are aware of this, has come out, but it's a little bit of a different indication. It's in the BRCA-positive patients that have 3 or more lines of chemotherapy. In Canada, most recently, when I actually put these slides together, I didn't have this information, but as of April 29th, as of April 29th, the indication has come through for both gBRCA, so germline BRCA, as well as somatic BRCA in the recurrent platinum-sensitive maintenance treatment of patients. So And again, I'll talk about the dosages and how many tablets patients have to take for it. So just because I am in clinical trials and we like graphs and all of that type of stuff, and I know one of the physicians said that if you put your thumbnail in between, there's a difference yesterday. So I do want to just point out that olaparib at the top there was 11.2 progression-free survival versus the 4.3 on placebo. So it is pretty impressive when you look at the graph that way. So special access program, when a drug is being looked at and has been given FDA designation, some drug companies will look at doing a special access program. So essentially, it's like compassionate. So it's that fill-in between the time that the drug is approved and getting the patients the medication that they need. So we started the special access program at Princess Margaret late 2015. We have over 28 patients currently enrolled in it. It is run through our outpatient clinic. So myself and some of the physicians went around to all of the nurses in the clinic and did some education on olaparib, because to that point, they had never actually used PARP inhibitors because they were always on clinical trials. So what we did was we set up a process in order to be able to handle this. We have the forms, the initial request forms in our clinic in little packages so that it's easy access, because if, healthcare team members have to go looking for things, it may forget and all that type of stuff. So we set up these little packages. We do have one coordinator who is responsible for helping assist with the initial sending everything through, as well as making the renewal request as well. And then we have one person who would report SAEs, so serious adverse events, any things that come up that we need to report to Health Canada or to AstraZeneca relating to their drug, then there's one person that is all centralized. So the way we've managed it is the patient is given Stemetil prescription along with their olaparib, and I've instructed the nurses to suggest to patients that they do take this about half an hour to an hour before they're taking their olaparib. It's 400 milligrams, which is 8 capsules twice a day. Okay, one cycle is 1 month. They're given a follow-up appointment, so we bring them in, we do blood work at day 15. So that's CBC, just checking to make sure that everything is okay. And then they have a return assessment, cycle 2, day 1, and then monthly thereafter. So with this group of patients, because the indication wasn't there, we have had it is BRCA-positive patients, but we've also been treating maintenance or post third line of treatment, so we used both settings for it. The one thing I will note out or point out is being careful with side effects related to drugs that you may be giving to prevent side effects. So Stemetil, sometimes you can see the restlessness, the pseudoparkinsonian jaw clenching, that type of thing. So we didn't see a lot of that, and then all of a sudden we were, okay, why is this happening? So sometimes when you increase something or suggest something for a patient to take to counteract another thing, you may cause other side effects, so you just have to be careful of that as well. We did at day 15, and every time they come in for their blood work, we do CBC, electrolytes, liver function test, just to be sure that everything is looking okay and that they're able to keep going.
How large are these capsules?
I'm going to show you.
Oh,
Well, it's not a real, they're not that big, but they're not small. So it is 8 capsules, and it is twice a day. So there is a food effect. So essentially, these patients should be taking it fasting. Okay, so this can pose some issues. I know they do suggest that at least an hour after food or 2 hours before eating. An hour after food and refrain from eating for 2 hours. So essentially that's the definition of fasting. We have patients who have been on olaparib or Lynparza for a very long time that actually set their alarm clock for 3 or 4 o'clock in the morning so that they can take their pills because they don't want to worry about the nausea, or they don't want to have to worrying about fasting for getting up in the morning when they're having their breakfast. So they figured out that works for them. And, again, everybody's different in how they deal with that. So this is the dose level reduction. So you're going to look at 200 milligrams. So just note that you don't go from 400 to 300. It's actually 400 to 200. So it's 4 capsules twice a day. And then if you have to go down again, it's going to be 100 milligrams, so the 2 capsules twice a day. So there is a tablet formation, which is a few less pills. However, that's still in clinical trial, and the dose is 300 milligrams twice a day. Okay. So essentially, majority of the research that is being put forward is through the Study 19 safety profile. So again, you're going to look at the top 3 there, which we've seen in the other PARP inhibitors, where it's nausea, fatigue, vomiting. Those were the types of things that they were seeing the most of. So this is essentially our experience at Princess Margaret. And again, it's not very different than what we saw with the other ones or what was reported either. So fatigue, again, everyone's experience is different. Some do feel it immediately, and some it's more of an accumulative. They have to listen to their body, report their symptoms, and again, because it's not technically in trials anymore, you can use dose holidays and dose reductions as your team sees fit.
When you talk about those holidays,
Yeah.
is there a particular key time?
So what we found, and I'll say that for kind of most of them, it depends on the protocol when you're looking at niraparib or rucaparib as far as how long you're allowed to hold for, because those are still in clinical trials. When you look at olaparib or Lynparza, essentially, if we see a patient on Monday and they're having fatigue or nausea or something like that, we would usually bring them back the next week. We'd hold it for about a week and then bring them back. And what we have seen is just that little break. You almost get like a reboot, and then they're able to keep going. So it's one of those things where some people bring back sooner, 3 days, that type of stuff, but generally for us, it's about a week. Yeah. So nausea, we try and do treating prophylactically and treating it early. Usually within the first 2 cycles, so I would even say within the first cycle, but most of the time within the first 2 cycles, patients are off of the Stemetil and off of anti-nauseas, and they're doing fine. They don't have a lot of nausea. I will put this in here, fasting versus non-fasting, because I do have some people that are doing the SAP, not on trial anymore, and they're actually taking it with a little bit of a snack. I'm just putting that out there. But patients have researched, and I'll go into some of the things that they've come back with and told us about what people are doing.
And how many drug holidays until you say this isn't working?
It's a good question. When we have protocols, those are usually specific that tell you exactly how many times you can hold and how long for and all that type of stuff. When it goes into general practice, it's going to be a little bit different. So there isn't a guideline, at least that I know of, that you can't hold for 5 times, that type of thing. Now, if you're getting into you're holding every other week, you may want to look at dose reducing, but it just kind of depends on what the comfort level is of the patient. Because again, if they're having this much difficulty and it's going to be in the maintenance setting, they may not want to go back on either. So it's having that conversation about, how many times can you hold, what it's, and all that type of stuff. So we did see some myelosuppression. So doing a transfusion, we did have some patients that had decreased white blood cells or neutrophil count, transfuse, Neupogen, and again, the drug holiday or dose reduction is needed. So acid reflux, this is actually one of those ones where if a patient had a baseline of acid reflux, it actually increased, or some patients it increased with the olaparib. Trying antacids, trying dietary changes, PPIs, looking at other causes, again, maybe they're taking something else. Drug holidays or dose reductions, again, as needed. So we did hear yesterday about MDS and AML, and it's associated just in the line of Lynparza, but it's actually being rolled out as far as all of the trials when it look at niraparib and rucaparib as well. So it's one of those things that are being watched for with the PARP inhibitors in general. So you need to monitor for weakness, weight loss, fever, blood and stool, shortness of breath, those types of things. And so essentially on the actual form for Lynparza for the SAP patients that do get information about it, it does say that the physician will be, or their medical team will be doing blood tests frequently and monitoring. And if their counts are low, then they will either hold or take off as they see fit. One of the other ones that's kind of associated with PARP inhibitors in general is pneumonitis. So I'm sure everyone's familiar with it, but just in case you're not, acute or chronic inflammation of the lungs that can be very vague in their symptoms, right? So it's cough, shortness of breath, fever, those types of things. And you need to ask patients to report, as I've kind of said all along, to report any symptoms that are kind of out of the ordinary. So I just wanted to show you 4 cases. Hopefully I'm not going too fast over time. Okay. Of some patients that we have. So this is the first case. So we have a patient from 2001 who had prophylactic surgery. So she's a BRCA-positive high-grade serous patient who had a really strong family history of breast cancer. So she had, as you can see, chemoradiation, prophylactic surgery. She recurred in 2006 and had chemotherapy again. She recurred in 2008 and went to a clinical trial with olaparib. So she started off with the 400 milligrams twice a day. Within 2 weeks, she developed a grade 2 fatigue as well as acid reflux, and then she also had a grade 3 neutrophil count. So according to the protocol, we had to do a dose reduction. So we reduced her down to 200 milligrams twice a day, and today, I saw her last week, she continues on olaparib and is doing well with very few side effects. You go from 2008 to 2016, there are going to be bumps along the way where I'll get older, those types of things, but it's actually reported AEs recorded to olaparib, there's very, very few. So the next one is the case study number 2. So this is a BRCA-positive high-grade serous ovarian cancer. She was obviously, as you can see, treated with multiple lines of chemotherapy. She waited a really long time for a PARP inhibitor. She was actually one of the patients that was lobbying and trying to get PARP inhibitors to come in mainstream treatment. So she was really happy when the SAP program came out. She started on olaparib in 2015, and at the same time, she started on an antibiotic. So when she came back to see us, she also reported having a baseline symptom. So I knew this patient from a long time ago. So with all of her chemo, she had sort of a nausea, underlying nausea. So when she came back to see me, after being on the olaparib for a while, she said it was actually worse than being on chemotherapy. And I was floored. Like, what do you mean? The nausea is worse. So we, worked with her. Why were we having such an increase in nausea? What was the issue? Like, why were you saying these types of things? So we did discover that she was on an antibiotic at the same time. It was something that, it was actually Cipro, something that you shouldn't really interact unless you're going to dose reduce the olaparib. So she continued to manage. We did, different things, suggested and all of our possible tips and everything to see how we could help improve that. But her acid reflux, and she was just not eating all that well. So in December, we did a dose reduction, and she continues on the 200 milligrams and is feeling really well. Yeah.
How old are these ladies?
I can't give actual ages, but I can give a range. So anywhere from 50 to, say, 75-ish. These are the ones that I am letting you know about, yeah. So case study number 3. So this is a patient who had surgery in 2002, chemotherapy, recurred, had chemotherapy again, radiation. Then she went into a clinical trial with olaparib. She is a BRCA-negative patient. She is high-grade serous. She continued to work full-time while she was on the olaparib from 2008 to 2015. Never required a dose reduction at all. And she recurred, unfortunately, in 2015, and it was a slow recurrence, so we actually kept her going on the olaparib for quite some time, even after we started to see the CA-125 go up and some changes on the CT scan. So she went on to another clinical trial with olaparib and cediranib in 2015. She recurred shortly thereafter and had chemotherapy, and now she's being worked up for another clinical trial. So if you think about it, when it comes to, we don't know what her somatic is because the somatic is still being tested. She didn't go on a clinical trial that tests for somatic. So when you think about the indications, she wouldn't actually be eligible for olaparib today. So she had a response from 2008 to 2015, and she wouldn't actually get the drug based on the indications right now. Okay, so this is the final one. So we have case number 4. This is another BRCA-negative patient. So she had surgery in 1997, okay? Multiple rounds of chemotherapy, radiation. She went on clinical trial with us in olaparib in 2009. She did really well, and then her disease started to percolate again in 2013. So we actually did surgery, removed an area of disease, and then went back onto olaparib. And she went from 2013 to 2015. Again, disease started to just slowly progress, so we kept her on beyond progression. And then she went on to a clinical trial with olaparib and cediranib. She developed more disease progression. She got chemotherapy, and unfortunately, she did pass away just earlier this year. But she, again, didn't require any dose reductions from 2009 to 2013. And again, another patient that wouldn't necessarily be treated with olaparib, or a PARP inhibitor in general, actually, because of the indications.
So this is a little bit different than what our usual standard of practice would be with chemotherapy several times plus radiation to go through surgery. So this surgery was a cytoreductive surgery yet, or was it a bowel resection?
No, it was a cytoreductive surgery. Well, yeah, so it just, 1997, right? So looking at, and then the great response for the PARP inhibitor, they decided to go back in and they were able to remove some small areas that were growing, and she continued on. So that's one thing I do want to make a point of saying is PARP inhibitors are not generally like your chemotherapy where you're going to do 6 cycles, you see your CA-125 come down, and then you just stop after 6 cycles and you wait, that type of thing. So you may see, depending on your teams, your medical teams, as well as the patients and everything, that they will continue on PARP inhibitors past progression. So you may see, and I think one of the physicians said that yesterday, where you're seeing some of the areas really well controlled, but one area may not be, so you can actually keep going on the PARP inhibitors.
So, and I think we saw with one of the other case studies that demonstrated a surgery as well.
Mhm.
And again, that was a cytoreductive type surgery
Yeah.
versus a bowel resection
Right.
and an ostomy.
Yeah, exactly. Yeah.
So that sort of, to me, is very different than what we've been used to.
Yeah, so every site is probably going to have different ways in which they manage patients, so you will see variations between. And again, as patients go on to PARP inhibitors and this becomes more streamlined, you may see different practices, and I think it's one of the things that we're going to have to look at standardizing as we learn more about the treatment of these patients. Yeah. Did you have a question?
All of your scenarios of radiation, is that full abdominal radiation?
So it was, this was a while ago, right? These patients are from a long time ago. We don't generally do whole abdominal irradiation anymore, so it just kind of depends. But yeah, those ones, because, I tried to use my long responders for examples. But you wouldn't necessarily see a patient that was going on to, a PARP inhibitor now, having had radiation previously. So I think that we need to look at patient expectations because they have done their research. They do know about PARP inhibitors, but we also have to watch what type of research they are doing and where they're getting their information from. So, we have had patients that have come in and said that, I've read online that I can take on Dancitron daily. And so for us at Princess Margaret, we go, oh, we don't normally do a Dancitron daily. So it's like trying to find what we would suggest versus what people are saying online. The other thing that came up was a patient said, well, you're starting me with 8 of these capsules twice a day. Why can't I just start with 1 and work my way up? And she had read online somewhere that somebody was doing that. So it's managing their expectations, managing also their research, what it is that they have come in with, what they have in their mind as well. Just because it's an oral medication does not mean that it doesn't have side effects. And I think I say that multiple times throughout the day. So in finding that new norm for patients as well, and like I said, not cleaning your entire house, looking after the grandchildren, shopping, doing all those types of things all in one day. It's finding that new norm and what works well for them. We also need to be really important, I've said that kind of all throughout, that we need to be informed about what it is that they're actually taking alongside of these things. You want to remember that there's prohibited fruits like grapefruit, grapefruit, and Seville oranges, and they should be in contact with you on a regular basis if anything is coming up or if they have questions.
So when you talk about prohibited with antibiotics, so do you give them a drug holiday prior antibiotics?
So it would, for trials, we generally look at a different antibiotic, one that is allowed. It will depend in practice how you want to manage that. I know that if you wanted to do, I think there is a suggestion that you actually reduce the dose of the PARP inhibitor if you're going to give an antibiotic. So it's looking at those types of things, but it's not just writing a prescription saying, here you go.
Look at the micros, see the
Yes,
sensitivity.
exactly. Yeah,
Okay.
yeah. And I think people almost forget sometimes that, it's now out of clinical trials, so I can just prescribe anything, right? Where there are prohibited medications. And we know that, if you're taking a blood pressure medication or if you're taking some other medication, there are prohibited medications, so you need to keep that in mind.
So have you had any experience where there's been a disconnected communication where a GP may have started something then without you knowing that that's the
Yeah.
case?
Yeah.
And there's been some challenge there and sort of the role of the oncology nurse then in ensuring the patient is having that transition of communication when they are.
Yeah, so I mean, for me, I've only been in clinical trials for 8 years. Now, some people say that, that's a long time, but we've always given prohibited drug lists to patients. So they actually know what they shouldn't be taking. So I always say to them, take that to your pharmacy, take that to your family physician, keep a copy on you, all that type of stuff. But that's when they're in clinical trial. When this goes to mainstream, and I've never seen a drug actually get to mainstream in my 8 years of experience, so it's a little bit different of knowing, how do you remind patients, how do you remind their, family doctors to remember these types of things. And a lot of it, I think, will come down to having that conversation at the beginning, just reminding them, and then having the patient take the onus of remembering that there's certain things maybe I should check with my oncology nurse before I actually take this. Yeah. And again, I think that, as oncology nurses, we've talked about keeping going on PARP inhibitors beyond progression, and I think this is a really important part for us, because this is not something that patients generally with ovarian cancer have thought about, or their families. So if you go in and the CA-125 is going up, and one area of disease, so it's that conversation about changing treatment. Whereas with PARP inhibitors, it's a little bit different. So having that education, having that conversation with your patients and the families about that is really going to be vital, because I don't know in other centers, but they tend to say a little bit more to the nurses than they do with the physicians. The nurses may have a little bit more time than the physicians to sit down and actually explain things. So it's a really important role as nurses. So just in conclusion, PARP inhibitors are being studied and used in women with high-grade serous ovarian cancer, either in the germline BRCA or the somatic BRCA mutations. PARP inhibitors are generally well tolerated, with nausea, fatigue being reported kind of in all three, if you see that trend obviously across there. And I do think that nurses have a really vital role at this time. It's a really exciting time for being a nurse in ovarian cancer, because we do have the ability to see new drugs coming through that patients will have access to. So I was asked to do some questions. Is that okay? I don't know. We don't have the electronic thing, but so Mrs. A has recently completed her second line of chemo for ovarian cancer. Her medical team has decided to start her on Lynparza in maintenance setting, this is the right one, yeah? Okay. Which food should she avoid? So A, B, C, or D? C, okay. Oh, yeah, C was the right answer, sorry. Next one. Mrs. A has been told she has G-BRCA negative, but is somatic BRCA positive. She's concerned about the effect this will have on her two daughters. So after discussion with her family team, her healthcare team, she's not worried about her family members at this point. This is because somatic BRCA is not hereditary. So true or false? So true. Okay. Yay! You guys know something? Okay, so number 3, identify 2 common reported adverse events with niraparib, rucaparib, and olaparib. A, B, or C, D? C. Good. So I just want to say thank you to the patients and their families, because without them, we would not have this information, as well as the symposium coordinators, AstraZeneca for helping with some of the slides, and to my team at PMH. The references are all there, and that's it.